So thank you very much for having me. I appreciate the kind invitation. I'm excited to be here. Here's my disclosures. So when we're talking about functional MR, I mean, this is, as has been mentioned, this is really a problem with the ventricle largely. It's not a problem with the valve itself per se. But there's generally, we break it into ischemic and non-ischemic etiologies. The more common non-ischemic etiology is when someone has a dilated cardiomyopathy. So you get the ventricle itself enlarges, pulls the papillaries in the valve apart. There can be cases where you get isolated annular dilatation without the LV dilating, but that's certainly less common. Whereas with ischemic MR, you get retraction of the posterior medial papillary, which pulls the posterior leaflet apart. Again, it's a ventricular issue, but certainly a different etiology. These tend to maintain a smaller annulus than we do with the dilated cases. Now, we know, looking at all patients with MR, that they just do worse. So this is a study looking at patients who have MR after MI. Those with mild and certainly moderate and severe MR have worse survival than those that don't. In patients who have heart failure from ischemic or dilated cardiomyopathy, those patients, again, with more MR have worse survival. Patients who have had a revascularization, those that have mild, moderate, particularly moderate MR, again, have worse survival than those. So obviously it's a big problem. What do the current guidelines say? Well, and again, we're just focusing not on degenerative, this is all functional, but patients who have severe secondary MR, functional MR, who are undergoing another procedure. Okay, it's a class 2A indication with really poor evidence, so it's level C. So I think most of us probably would treat these patients if severe MR that have another indication. But what about the patients who aren't, who just have the severe MR without another procedure? And this is a class 2B indication. Additionally, it's a 2B for patients who have moderate secondary MR who are undergoing a cardiac procedure. Well, why is this? Why are we not looking at both better evidence and a stronger recommendation? Sorry that the formatting of this got off, but so based on this, you'd think more patients would be having surgery. But in this study from Duke, they looked at patients with functional MR, EFs greater than 20, and basically of the entire population, only 11.4% of these patients were actually undergoing a surgical management of their mitral valves, and it tended to be the patients with a better ejection fraction they were more aggressive about treating, but those patients who had a worse ejection fraction, in the 20-30%, less than 6% of the patients are actually undergoing procedures for this. And this is not unreasonable. The data here, this is looking at a number of studies treating MR with annuloplasty for ischemic patients, and basically you can see that even at the early 30-day range, there's already a 20% incidence of 2+ or greater MR, and as time progresses, the amount of MR also significantly increases. In the most contemporary study that was actually looking, we took these patients and said, hey, is it better to replace these patients or repair them? This was from an NIH-funded cardiac surgery network trial. And the endpoint of this trial was actually reverse remodeling. And they found that in terms of survival, or the composite endpoint, there was actually no difference between mitral valve or mitral replacement. However, they looked at the patients that had repair versus replacement. The recurrent MR, even at a year, and now even there's 2-year data, was much worse than those that were repaired. So in the replaced patients, only 2.3% had moderate MR, no severe, whereas in the repair group, almost 30% had recurrent, had 2+, moderate MR, and even 4.2% had severe MR. However, this doesn't totally dismiss mitral repair in this population. When they looked at the patients that had repair that actually had a good result, so we took, on the left is those who had repair with MR, who were repaired, still had MR. On the right is those patients who were repaired without MR. They actually had the most aggressive response in terms of positive remodeling of their heart. So there is a population that does do well with MR. And so ideally, if we could identify that, we could, hopefully help, select which patients will most benefit. Dr. Krohn took the same population and took them out to 2 years, and you can basically see that in terms of the severe patients kind of stayed the same, but over time, some of the people with no MR progressed to moderate MR, indicating a progression of obviously the ventricular pathology, because the ring, presumably this isn't, maybe a small number was ring dehiscences, but this was probably mostly just patients who have progression of their ventricular pathology. And importantly, as you might guess, the patients who had significant, those patients that had recurrent MR had a higher death rate than those that did not have, that had a successful repair on the onset. Now, we talked about predicting, and there has been various studies looking at which patients will do better. These are echo parameters. I'm not going to go over them all, but basically, they're things that would make sense. So those patients whose valves are really worse, the annulus is much larger, the coaptation distance is greater, those whose ventricles are larger, bigger burned out ventricles, these are the patients that don't do as well. And probably I think the implication for this is that we need to be finding these patients or intervening on these patients sooner if we're really going to be able to help them. Now there are other studies looking at durability. It's not just that the study I just showed you. This group looked at 78 patients who had good long-term follow-up and still had significant recurrent MR, and 3 to 4 plus MR was in 20% of the patients with a mean follow-up of just over 2 years. So it still is a significant problem. Now, the group at Cleveland looked at their patients with ischemic MR and compared those that had a CABG with the addition of an annuloplasty versus those that didn't. And the 2 points here, one, obviously those that didn't have the annuloplasty had more significant progression of their MR with time, but you do also see that perhaps less recurrent MR than we've seen in some of the other studies, but still by 5 years, it's in the 20% range. So again, with the annuloplasty, there was less MR, quite a bit. I mean, this is pretty obvious. However, in the same population, we looked at survival, and there was no difference. So while there was less MR in those with an annuloplasty, there was not really a survival advantage to treating this population. And that's one of the big questions with this. Are we going to really be able to help these patients? Perhaps in the only positive study that showed a survival advantage was the Restor trial, and this was this Coapsys device that basically changed it was like a spear going across the ventricle to change the ventricular shape. So rather than doing actual mitral surgery, they said, hey, the problem is the ventricle, let's kind of change the configuration of the ventricle to get rid of the MR. These were all ischemic patients that had CABG, and actually those that had the device placed, so the repair of their MR with this device through a ventricular approach actually did have a survival advantage. The study took a long time to enroll. The device, incidentally, is not being used or approved, but this is kind of one indicator that maybe there can be a potential survival advantage if maybe the focus should be more on the ventricle. What about the patients with a dilated cardiomyopathy? This was from the ACORN trial, which was the core cap device, which was basically a net that sat around the heart with the idea of, one, just kind of preventing it from dilating, but they also think there was some beneficial inflammatory effects perhaps from the device that might help the ventricle to remodel in a positive way. But these patients also had mitral valve surgery. Most of them had, 84% had a repair, whereas the other 16% were replaced. They were all low EF patients. The operative mortality was 1.6%. And in this population, and even with and without the device, there actually was an improvement. So this is not as much the ischemic population as most of the talks I've already showed you, more of the dilated patients. And over time, they had an improvement in both their diastolic and systolic volume, though after there was a trend after 5 years that maybe it was starting to get a little worse again, but still much better than where they started at baseline. And with this trial, the addition, even those patients who didn't have this core cap device still did have an improvement with just mitral surgery alone, though those that had the device had a better benefit. Now, probably one of the biggest, how can I say this politically, but someone who thinks that no one else can, that we're doing a lot of these treatments inappropriately and we're not undersizing rings a lot, but even in someone who's very aggressive about really reducing the annulus in these patients and effectively gets rid of MR, they looked at their patients and they compared them to those to kind of control patients without surgery. And so despite getting rid of MR in a lot of these patients, it actually doesn't improve survival. And that's the big issue. I mean, again, the problem here is the ventricle. So we're maybe getting rid of the mitral regurgitation, but are we going to affect their survival, which is an important question to ask. That being said, if there are other benefits, if we keep the patients out of the hospital, they feel better, that doesn't mean that it's inappropriate therapy. Just quickly, Dr. Bailey already discussed the mitral clip, but there is several studies looking at how these patients do, the functional patients with a mitral clip, and in the U.S. we're limited to COAPT, but outside of the U.S. about 80% of the mitral clips are done in functional patients as opposed to degenerative. But in the Access EU study, they looked at the functional patients, kind of broke them down between lower and higher EF, but they also broke down, the patients with the better EF tended to be more frequently non-ischemic patients, whereas there was a similar distribution in those patients with an EF less than 30. But it was a highly symptomatic group with close to 90% of the patients in class 3 or 4 heart failure, and it was a high surgical risk group. But they found, and this is only out to a year, but the patients who had the clip, and this is just compared to their baseline, there's no control group, but they had certainly an improvement in their MR grade, with close to 80% being in 2+ or better MR. Their functional class, 71% were in class 1 or 2. Their quality of life metrics, a significant improvement, and they were able to functionally do better with a better 6-minute walk test. So this population, let's say that maybe there isn't a survival advantage, hopefully there is, but if there isn't, we are making these patients we're making them feel better, and I think that is important. So in concluding, functional MR, it's clear that populations with MR do worse. Repair, unfortunately, does result in a significant early reoccurrence, which is likely the result of the continuation of their ventricular pathology, which started the MR in the first place. I think there might be a quality of life benefit to fixing it. There is a suggestion that maybe the non-ischemic patients have a lower reoccurrence rates than those that have an ischemic etiology. But I do think that given kind of these results, as well as the morbidity of surgery, particularly if there isn't going to be a survival benefit, that there really is ample room for transcatheter therapy in this population. Thank you.